as well. Alrighty, so thanks everybody for joining us. This is the ACES quarterly event for July for the City Match Near Collaborative. And I just want to thank everybody for joining and also give you a reminder to keep yourself on mute unless you have a question throughout the presentation. And you can also put questions in the chat box and I'll be keeping an eye on that. In case this is your first event, this is the ACES quarterly once every 3 months in January, April, July, and October. And it's really, the event is held to promote community understanding about ACEs and resilience and to support ongoing. And today we have Tima Jose and Meline Velazquez. And if you have joined us in the past, you may remember Meline, who spoke previously with us about cultural humility. So we're really happy to have her back. And just to give you a bit about their background, Tima is a licensed clinical social worker who's certified in grief counseling, and she's a bereaved mom. She supports and advocates for families impacted by infertility and pregnancy and infant loss. She's a military social work therapist, and she supervises licensed military social workers, domestic violence advocates, and home visitors for the Navy Counseling and Advocacy Program. As an advocate for maternal mental health, Tima and a team of bereaved mothers was instrumental in getting certificate of birth resulting in stillbirth legislation passed in Washington State this past April. She's board certified chair-elect for Return to Zero Hope, which is a national nonprofit organization raising awareness about pregnancy loss. She also volunteers her time facilitating support groups with bereaved parents. Tima is also Secretary of Perinatal Support International Washington State Chapter Advisory Committee and member of the Snohomish County's Perinatal Mental Health Task Force. And Meline Velazquez is a Latinx psychotherapist specializing in perinatal and infant mental health. She's a social work doctoral student focusing her research on anti-racist and anti-oppressive practices in mental health. Her practice supports women and clinicians working on practicing from an anti-oppressive framework. She sits on the board of the Washington Association for Infant Mental Health. She also serves as the chair for the Florida chapter of Postpartum Support International and as a past president of the Florida Association for Play Therapy. She's an author and speaker who has presented at multiple national conferences and loves increasing awareness of the intersection of perinatal, infant, and child counseling services. So we are really lucky to have them both here with us today to talk about perinatal mental health and supporting communities of color. The presentation should be about an hour to an hour and a half, and there will be time for questions at the end. So feel free to either hold those with you or put them in the chat box throughout the presentation, and we'll get to them during the Q&A section. And I will go ahead and let you take it away.
All right. Well, good afternoon, everyone. I'm going to go ahead and share my slides. I can start that first. Okay, I think we're all set. So thank you, Maddie, so much for this lovely introduction. In the spirit of BIPOC Mental Health Month and Black Maternal Mental Health Week, which started this week, I want to start us off with a quote from Michelle Obama. And the quote is, "We need to do a better job of putting ourselves higher on our own to-do list." So in the spirit of self-care this week, I want us to sort of focus on how can we be, instilling this message within ourselves and within our clients that we work with. And for those of you who are not familiar with Black Maternal Mental Health Week, it's an awareness week spearheaded by Kay Matthews, And she is the founder of the Shades Blue Project. And it's dedicated to raising awareness of Black women's and Black birthing people's mental health needs across the perinatal period. So we felt like this presentation really added to that discussion today. And as Maddie mentioned, I'm Kima Toze, a little bit about myself here. Is the next slide. My personal story is through, my story of, or my time through becoming, my motherhood experience, excuse me, is what I'm trying to say. I have had personal experiences with PMADs and other health complications, as well as loss. And so I see a lot of my work in this field being raising awareness, advocacy, and peer support for families, and through my volunteer work.
Yakima, my name is Meline Velazquez. I am a social worker. I moved to Everett in April of 2019. Before that, I had been living in Miami. And a little bit of my history, which I think is relevant to our topic today, because it's always important to kind of ground ourselves in what our identity and our reality is. I am an immigrant. I was born in Venezuela. I'm also a daughter of immigrants. My parents were Cuban and Colombian, and they both migrated to Venezuela. And then when things got really scary in Venezuela, we migrated here. I am also somebody who lived most of her life as a brown person. I have a condition that's called vitiligo. If you're not familiar with vitiligo, it's a condition where your immune system attacks the cells that produce melanin. I developed it when I was 16, and it started with 2 tiny little spots. And when I was around 27, 28, it sped up exponentially. And so now I navigate my life very differently than I lived my life, most of it. And so I think that that's a relevant thing to share when it comes to identity as I step into my brownness. Is a brownness that I no longer carry outside. It's a brownness that people don't recognize. And the way that I came into the field is I started as a child therapist. I have my own history with ACEs. I think my number is 10 plus. And I recognized that we were paying a lot of attention to the needs of children, and that there was this huge need that was missing, which was the needs of parents. And so I'm excited to be able to share with all of you. So next we have the objectives. So you have these slides, you can read through this. Our main goal today is that you walk away with some actionable tools so that you can strengthen your practice with diverse individuals. So before we get started, I want to invite you to share with us a moment of mindfulness. And so this is an invitation. I can't see everyone, but if you happen to have your cameras on, I'm going to invite you to take your camera off so that you can choose to participate as it is, or you can choose to participate in a way that feels more comfortable for you. So we're going to begin with, if you have your camera off, just kind of sitting comfortably, and whatever comfortable means for you. Sometimes for me, it means placing my feet on the ground. Sometimes it means placing my feet up on the chair where I feel cozy. So wherever your feet need to be, wherever your body needs to be, see if you can sink a little deeper into that seat. And we're going to begin with 3 intentional breaths. In through your nose, and out either your nose or your mouth, whatever feels more comfortable for you. As you take each breath, see if with each inhalation you can inhale for a little longer and exhale for just a little longer each time. I invite you to notice any thoughts that might be coming up for you. Maybe thoughts about what we're doing. Maybe thoughts about what might have happened later, thoughts of this or of that. Notice them and see if you can sink into your body again and sink into that breath. Notice any thoughts that might come up for you. Maybe thoughts of this, notice your body, any sounds that you might hear, maybe sounds outside, sounds of pets or children or traffic, sound of my voice. And see if you can go back to the breath. As you take another breath, I'm going to invite you to listen to this quote. And this is a quote by Ruth King. And Ruth King does a lot of work on mindfulness and the intersection of mindfulness and race. And her call to us is we must be clear in our intentions regarding what we want to wake up to, and then attend to them mindfully. We all need an intention beyond righteousness. Ask yourself, what is your vision of racial healing? Why is this important to you personally? What do you need to face up to and own in order to stay awake to racial suffering? And how would this benefit all beings? The other invitation here today is to lean into what Resma Manikim, who is the author of My Grandmother's Hands, calls clean pain, which is our capacity to lean into discomfort and to look at it, right? As opposed to push away from it, and as opposed to, leaning into anger and frustration, but just kind of leaning into the discomfort. And whenever we choose to not lean into discomfort, I also invite you to explore something that Resma also says, which is, what is the price that I pay for not leaning into the discomfort? And what is the price that individuals from historically marginalized communities pay when I don't lean into that discomfort? I invite you to take another breath. Notice your body. See if there's a part of you that might need a big stretch. And when you're ready, if you feel comfortable, feel free to put your cameras back on and join us as Kima takes it away.
Thank you so much, Meline. That was beautiful. So Meline and I really want this presentation to be interactive, and we don't want to talk at you for 90 minutes. We already know that there's a lot of wisdom in this space, and so we want to capitalize on that today. We'll have an opportunity for group discussions and also a Q&A, but feel free to type in the chat pod if you have questions throughout the presentation, or to come off of mute, and we will gladly answer your question. Before we dive in, do we have any questions? Okay. So perinatal mental health in the Black community. So I wanted to just start off with talking about some myths about Black mental health. As a Black cisgendered woman myself, I recognize that not all birthing people who identify as Black or African American are the same or have the same experiences as I do. I'm speaking from my personal experience, as well as my experience with birthing people that I've worked with, or that I know, and also any general trends that we know in the community through research. Mental health in the Black community has always been a taboo topic and not openly discussed. And so here are some myths that I wanted to point out that are pretty poignant. The first one is Black women are strong. Particularly for Black individuals, there's a pervasive belief that being a strong Black woman is the only identity that you can have. For many, being strong is more acceptable than being open and then being vulnerable, or taking the chance that you're relying on someone else or depending on others. It feels a lot more safe. It feels safer to depend on yourself. We also know that this myth tends to do more harm than good in situations where people need the right type of support, or they're struggling with their mental health and they're trying to rely on their willpower alone. The strong Black mental health, the strong Black woman stereotype, it does have its roots in slavery, and it does perpetuate through the media as well as within families. I personally have experienced this stereotype. I see it, in my own family makeup. I see it in myself. And sometimes I have to take a step back and think about, am I perpetuating this stereotype of trying to be strong and be self-reliant? So we know the myth is definitely a stereotype that needs to be debunked at any opportunity that we can get. And so a nice reframe for this is that we are resilient, not strong, and not superhuman. And I just want to repeat that again, because I think that really speaks volumes to where we want to go in the future in terms of Black mental health is resilient, not strong, and not superhuman. I like this statement. It really recognizes the incredible resiliency within the African-American community and all the historical traumas that our community has faced. And it also looks at this as a characteristic of the community versus just an individual trait of being resilient. The next point here that is a pervasive myth, is that suicide is not a problem in the Black community. So in the book, Apologetic Guide to Black Mental Health, it is a really good book that I do recommend you read if you haven't had a chance. And it's by Dr. Rita Walker. And in this book, she talks about Black mental health in general, but she points out that suicide in the Black community is an issue that needs to be addressed and is often overlooked. So in this book, she talks about the myth and that suicide is not an issue. And what she calls is low-key suicide. Another way to think of this are behaviors that a person engages in that leads them to premature death. So this can be neglecting physical health, having a poor diet, struggling with addictions. These are things that can put someone at higher risk for premature death. And her research has also shown that suicide risk for Black youth and young adults is increasing. And it's particularly because youth are seeing themselves as being strong. Again, going back to that strong person myth, that if you rely just on your strengths and abilities as a protective factor and not on spirituality or faith, which we know has historically been a part of the Black community, she has seen a lot of increase in suicide rates among Black youth. And so what this book really talks about is the breakdown in the psychological resilience in the Black community, ultimately putting Black people at higher risk for suicide. The next myth is therapy is not for Black people. For many BIPOC communities, seeing a therapist is not a thing. Talking to someone in your inner circle, talking to someone in your immediate community is a lot more acceptable, is typically viewed as a trustworthy resource that you can rely on versus going to see a therapist. So it's not uncommon for an individual to want to speak to a pastor at their church, maybe their hairdresser, a barber, a coworker, a relative, anyone but a professional mental health provider. And so we are not, I'm not saying that's necessarily a bad thing. I think it shows the resilience and the resourcefulness within the BIPOC communities. However, we know that if someone is struggling with a mental health condition, they really need to see someone professionally to address that in an adequate way. So the stigma attached with going to see a therapist or being in therapy, or this idea that, I'm crazy if I need to talk to someone professionally, it creates a huge barrier for our community to even talk about therapy on, in general, and also to go make an appointment to see someone. So the next myth is all I need is prayer. So we know that faith in God and higher power and spirituality are, huge sources of strength in the Black community. The Black churches have been, foundational for the Black community in fighting racial inequalities. So it's pretty much woven into the cultural identity of a Black person for the most part. However, we are seeing some trends in younger African Americans leading towards not being so much into faith or using the church as a resource. So 1 in 5 Black Americans claim to be atheist or agnostic. And so with younger generations, that number is increasing. But by and large, Black Americans are more religious than the US population overall. So church is a foundational and a huge influence on Black wellness that we want to tap into. But we also want to recognize that you can't pray away mental health conditions or problems. They really need to be dealt with head on and by mental health professionals. I do also want to recognize that faith and spirituality are great protective factors. So I'm not saying that we need to do away with them, but we need to also add on to that with professional support. And if someone needs medication, then really looking into those adequate resources. So thinking about the myths that we just talked about, let's look at some factors for good mental health. And I just kind of want to get your some responses from you all about this. So I have 2 questions. What do you think makes up good maternal mental health? And you could type it in the chat pod or you can come off of mute. What makes up good maternal mental health? And I have to look at the chat pod. Here. Are we seeing any questions?
Yeah, do you want me to read what's in
Yeah,
there?
that might be helpful. It's hard to see.
Okay, we have lots of support, a good
Mhm.
support system, access to care, having a support system always near to you to help you feel your best, whatever that looks like. Yeah, listening ear, self-care, boundaries,
Yes.
having your needs met, ongoing perinatal care with multiple postpartum visits. Absolutely. Feeling of being connected to others, health supports, and engaged in pro-health behaviors. And there's a lot of other.
Right. Yeah.
Knowing where to go.
Yeah, that's so important. All of those are really great responses and spot on. We also know adequate housing and employment are important too, and they do impact maternal mental health as well. What about, what do you think derails good maternal mental health? So what do you think gets us off course? What are some of those factors?
Exhaustion, financial challenges, isolation, lack of support and resources.
Lack of support. Yeah. Did you say
Judgment by
trauma?
others. Yeah,
Oh,
history of trauma and judgment.
judgment, yes.
Stress that you're not doing the right thing for yourself or your baby.
Like self-judgment, yeah.
Lack of understanding cultural differences.
Yes, cultural myths and stereotypes. The isms is another thing I like to mention. Family violence is another huge derailment from good mental health. Great. Well, thank you guys for participating in those questions. They were all spot on. And we'll talk more about that. So you all pointed out, a lot of what we call risk factors. And these are things that do derail good maternal mental health, excuse me. And one key thing to remember is that individuals in every culture, age, income level, or race can develop a perinatal mental health condition, or PMAD is what we call them. For BIPOC birthing people, being Black is not a risk factor, but racism is. And so I think it's a misconception. And so I want to clear that up. If you've heard that before, that being Black is a risk factor, or being BIPOC, it actually is racism or structures in place to marginalize others that creates the risk factor. Up to 20% of birthing people develop maternal mental health conditions such as depression and anxiety, OCD, and psychosis. For Black individuals, though, the risk is almost twice as high. And also, we know that a history of trauma, including interpersonal violence, any generational traumas that someone has experienced or within their family, has a big impact on mental health. When someone also, though, lacks adequate social supports, economic resources, or has a personal history themselves of mental health conditions, that does create a perfect storm. So we want to be thinking about that and be mindful of what those risk factors are, and also the impact of racism and inequalities that add to someone's stress load. So a key takeaway here is that the result of being a member of a certain group increases the risk, not being, of that group or identifying with that group by itself. So here I have a couple slides just talking about some mental and health disparities among Black birthing people compared to other birthing people. So according to research, is what we know is that nearly 2 in 5 women of color experience depression after giving birth, and almost double the rate faced by new moms overall. And nearly 40% of Black birthing people experience a perinatal mental health condition. So again, those numbers are higher and they're less likely to get treatment, which is unfortunate. And we'll talk about that in the next couple slides. Some of the reasons for lacking access to treatment include things like lacking screening for PMADs, lacking follow through when someone sees a provider, either the referral source is not a good referral source or there's no follow through in getting the treatment service. Black birthing people are also 2 to 3 more times likely to die after childbirth compared to women of other races. Native American women and Alaska Native birthing people are 2 times more likely to die as a result of pregnancy or complications as well. So I think oftentimes we miss that group in terms of the risk factors as in looking at BIPOC communities. And so we do have a huge, maternal mental health crisis going on here that needs to be addressed. Much of the research, though, is saying that contributing factors for this are things like structural racism, unconscious and conscious biases from health providers that they come into contact with. So I thought this was an interesting study. So when we think about what is causing the barriers to for Black birthing people to get treatment, one study surveyed 481 Black and white individuals 6 months postpartum and found that Black birthing people with postpartum depression were less likely to actually seek or accept medication treatment or ED therapy, and they were more likely to accept spiritual counseling instead. Overall, Black mothers were less likely to report stigma associated with postpartum depression therapies. And so the study concluded that more research on the barriers to treatment is needed. And so what is getting in the way of Black birthing people accepting treatment the study was not able to find that information or find out why. But as we know, the study thought that, stigma would have been one of the key factors, but it actually wasn't. So more information and more research needs to be conducted about that. But we also know, just in general, for BIPOC communities, some common barriers to mental health care, things like high cost of care. So either not having proper insurance or being underinsured. Cultural barriers. So maybe mental health providers that they are trying to seek out to get assistance with don't have a good understanding of the cultural experiences of Black birthing people, or there's a disconnect where they don't feel they can go seek treatment with certain providers. Stigma is still a huge issue, not only within the community, but outside of communities, looking at communities of color, there's stigma about, mental health conditions within the community. Racism, bias, and discrimination in treatments and settings are issues, and also lack of transportation, childcare, and just getting time off from your job. Maybe you don't have paid leave or proper coverage to take care of those things like, making appointments or taking care of your health care. So this next slide talks about a term called weathering, and I'm not sure if you all are familiar with it, but it was coined in 1992 by Dr. Geronimus. And so what she was doing is, or what she has also done, is looked at studies of women's fertility. And so what she observed is that Black birthing people don't have the same prime childbearing years as their white counterparts, which I thought was really interesting when I was looking through her research. She found that the prime childbearing time for Black birthing people was actually in their teens, teenage stage. So it's also the time for lowest risk for Black birthing people. So what this ultimately means is that in the United States, Black birthing people are more likely to have a healthy pregnancy in their late teens than they would in their mid 20s. She defined weathering, and what she says is the weathering hypothesis is this idea that the health of Black birthing people may actually begin to deteriorate earlier in adulthood as physical consequences of cumulative socioeconomic disadvantage. And what she called is a toxic stress that is triggered by discrimination, insults, microaggressions that Black people experience in America is actually aging their bodies inside and causing sort of a premature death is kind of what she was describing, which I thought was pretty fascinating and interesting information. She shared that Black birthing people experience what they call a double jeopardy because of gender and racial discrimination. And so, literally what's happening is Black birthing people are aging faster internally. And I don't know if you all saw an article, I think it came out last year, I want to say, is when I saw it, where there was, so it was research from proceedings of the National Academy of Sciences, or PNAS, found that Black newborns who are cared for by Black doctors or Black providers ultimately have less likely to die. And so they saw that ethnicity played a major factor in the outcome, in positive outcomes for those babies. So this slide just sort of highlights the importance of screening. And so we know that screening is a gold standard, especially universal screening, not just screening once, but screening multiple times. And so I wanted to highlight some screening tools that you may already be using in your practice, but that are highly recommended. So the Edinburgh Postnatal Depression Scale. This aids in determining whether an individual is experiencing symptoms consistent with PMADS and needs further mental health support. The PHQ-9 is also a really good measure, often used in primary care settings. The postpartum stressor scale. This is a 9-item scale, and it looks at 3 basic categories of stressors for a birthing person. So this would look at baby care, well-being, as well as any work stressors that person is experiencing. The CAGE is a substance abuse screening tool. And so it looks at the use of alcohol, and it's a really short measure. It takes about a minute to administer, and it's really meant to find out if a person drinks excessively and if they need treatment for that. I think this is really important too, because with COVID, we have seen numbers increase in the use of alcohol by women. And we also know that alcohol is typically a coping mechanism. And there's a lot of information out there about women coping with alcohol, coping with the stress of the pandemic and using alcohol for that. So screening is going to be important. And then lastly, the domestic violence screening tool. So I just added HITS as a screening tool, but of course it doesn't have to be this particular one. We also, we know that IPV is a risk factor, so we want to be asking questions about domestic violence. And again, IPV has been increasing under COVID as well. So I think it's just important that those questions are asked. And so we know where people are, where they stand and what support they need. So these next two slides are just questions that, I put together in my own, thinking about my own experiences, navigating systems, going through my own traumatic experiences through motherhood. I thought this was important for providers to be asking, particularly mental health providers, because this looks at, does a person that you're working with, do they have experiences with trauma, loss, or racism? What is their experience like navigating systems of care? And also, it gets to the meat of what are some cultural practices that would be important for them. So we'll just kind of go through each question. The first one is, what does your support system look like right now? And is there someone you would like to bring to your visits for emotional support? I think sometimes we don't often ask that last piece, because we may not be thinking about someone's support system and whether they want to include them in any kind of session. But I think it's important to highlight that it's possible that they can bring a support person with them. Next question is, what has been your experience with pregnancy and infant loss or pregnancy complications? And so I thought this was significant given the numbers, given the research that we know that Black birthing people and BIPOC communities have a higher number of or experience pregnancy and infant loss and traumatic births a lot more commonly. The next question is, how would you describe your past experiences with providers and systems of care? Really getting to, have you had experiences with overt racism? Have you had challenges getting your needs met in systems of care, and what was that like for you? The next question is, are there cultural, ethnic, or religious identity practices that's important to you? Again, from a cultural humility perspective, we want to be finding out more about our clients, people that we're working with, and not assuming we know what their cultural experiences are. The last question is, what do you need from your treatment team to feel fully supported? And I really like this question because I think oftentimes we don't think about the different people in a client's life, or in a client's life. So if you are the provider, you're a therapist, for example, who else is working with that same client? And do they feel fully supported by that treatment team? And if they don't, then a part of your role, which we'll talk about later, is how do you get them to feel supported? What do they need? And what can you help them with that? And now I'll turn it over to Meline.
Thank you.
Do you want me to stop sharing?
No, I think I can share. There we go. And so, thank you, Kima, for that really good presentation. I think you'll see that there's a couple of really good comments on the chat. And so I think that this is a really good leeway into how we think about ACEs. That historically, when we think about ACEs, we think about, I'm just going to time myself to make sure that I'm not talking too long. This idea that a child's first ACE is exposure to a parent that has untreated mental health condition. And I invite you here to really think about the shift of that child's first ACE is the system in which they grow in, right? That we cannot look at the experience of what it's like to grow up in this world without looking at the systemic barriers that individuals experience, especially when it comes to Black and Indigenous communities, right? That the stress that that parent is having as they're carrying that child to term, right, is going to be wired into the nervous system of that baby, right? So, just a different way to look at what is the first ACE, right? The first ACE is those stressors that child experiences. And that we really need to have a systemic lens as we're looking to implement interventions, right? We have to think about, what is that person's environment, but also what are the policies that are in place, and what is the state climate like, and not climate as in temperature, but what is the political climate like, and what is the national climate like, and how does that add right to the stressors that individuals are experiencing. And so many of us here are very much familiar with ACEs, and so this is the original study in the 1990s. Kaiser Permanente and the CDC embarked in this really huge study. And these were the first original 10 ACEs. Right. Back in around 2012, 2013, the Philadelphia Committee really expanded ACEs to apply to the experiences of BIPOC communities. And so we have what we know as the urban ACEs, which is really an expansion, right? To look at system-wide, right? That we're not only seeing what's happening inside of a person's home, but that we also have to think about what is that individual's life like, right? What happens as that child navigates the world, right? And keeping in mind that when we're thinking about perinatal mental health, we're thinking about what is that child's life like, but we're also thinking about what was that caregiver, right? That birthing person's life like, right? And what are the levels of pain, right? What are the ACEs that they're carrying with them as they're now thinking of becoming parents, of have become parents, right? And the barriers that they're facing, and how that's going to add to mental health outcomes. And it's going to translate into outcomes of that child, right? In terms of physical development, emotional development, in terms of social emotional development. And this is important, right? Because as we're treating people in whichever capacity that we're treating people or working with people, we really have to have that lens that we're looking at historical trauma, and that we have to name historical trauma, and we have to conceptualize it into treatment. And we have to talk about it, and we need to make sure that our organizational policies reflect, right, the very reality that BIPOC communities experience. Because when we don't, right, we really miss this really huge risk factor, right, which is the trauma that people have, right? And it's very important for us as providers, right, those of us that are therapists, or maybe some of us here might be prescribers, that we cannot therapize the oppression out of an individual, and we cannot medicate the oppression out of an individual, right? So it's kind of like a different shift in thinking. So as we think about that very first ACE, right, we want to think about how that brain is wiring, but we also want to think about that network, right, of systems that intersect, and that caregiver is experiencing, right? We have a special lens today on race, but I also encourage you to always keep that anti-oppressive lens as well, thinking about the different identities that people experience that are going to face barriers. Because the reality is that the barriers that I'm going to face as a white passing Latina are going to be very different than the barriers that a Black non-binary caregiver is going to experience, right? And we have to keep that in mind as we're working with communities, especially when we're working with communities that we might not be a part of. So moving to the spectrum of mental health complications, you should have these slides with you, and you should also have a worksheet that has a little cheat sheet of the different perinatal mental health conditions and kind of symptoms of them. So I'm going to do a quick review. And hopefully, if this is something that interests you, you'll find more training on it, and hopefully you'll find something helpful here. And so I'd like to start with this slide of like, what do perinatal mental health complications look like? And I love to include these really happy, loving photos because it's a good reminder for me that we can look phenomenal on the outside and feel completely crummy on the inside. And that as humans, especially BIPOC communities, and especially individuals that have been socialized as women, we're really good at wearing a mask. We're really good at looking like everything is completely fine when in reality, inside things can feel like they're falling apart. I've had clients tell me, the doctor told me that I couldn't be depressed because I was wearing makeup. That if I had been depressed, like I wouldn't be wearing makeup. The doctor told me that I must not be as bad as I'm saying that I am because, I'm presenting in this way, because I was dressed up, because I was wearing high heels, right? And that these are very real stigma and biases that we carry, right? That we might come from that sense of like, if someone looks good, it means that they're feeling good, right? And, I imagine that many of us here know this, but it's important to continue speaking about it, because if I'm hearing it in my practice, I imagine that you are hearing it in your practices and with the people that you work with. So really thinking that these are the stories or the phrases and the words that people are going to come share with us that are going to be our clue that there might be something else going on, right? Especially that scary one when someone shares, I feel like my child might be better off without me, right? A really big clue, right? That regardless of how that person looks on the outside, right, that we need to screen and that we need to do better by individuals. The biggest teller for me is asking people, have you been feeling like yourself? Are you feeling like yourself? And I find that this question is meaningful, even if there was a bit of depression or anxiety prior to the perinatal period, because things can feel so different. For many individuals, I find that the suffering that happens in the perinatal period is so sudden and so it shifts so suddenly and so intensely that it's extremely overwhelming. And it's important that we provide services quickly, to kind of relieve some of that suffering. And that even when there was a prior depression, that there is still going to be a shift in presentation, right? That symptoms might worsen, and because it's a very unique period. And what makes perinatal mental health complications really unique is that a lot of what the person is feeling has to do with themselves as they're transitioning into this role of a parent and their capacity to take care of the baby. So perinatal depression can look very different for a lot of people. On what spectrum we have individuals that can feel extremely depressed, where they're crying, there's sadness. On another spectrum, we might have an individual that's just feeling numb. I feel nothing. I'd like to share here the story of the very first time that I saw perinatal depression, and it was a young woman that I had been working with. And now she had been pregnant, and she had been so excited and so joyful and so happy to have this baby. I'll never forget, and I'll share one risk factor, which is homelessness. I'll never forget the maybe fourth day, like when she had come back from the hospital and someone came to get me and they were like, there's something very wrong. And I'll never forget, I walked into her room and here's this individual who looked transformed, and the lights were off and they were sitting in their bed and there was a flat, face just looking down, and there was a baby in a crib, or in a bassinet rather, but the baby was on the other side of the room facing the wall, right? This person couldn't bear the pain, right? The shame, the feeling of worthlessness at looking at her baby, right? And so there can be a very real shift that people experience. A lot of times we pay a lot of attention to perinatal depression, but we don't really consider anxiety or some of the other conditions. Anxiety is very, very common. A lot of these conditions are co-occurring. And so somebody with anxiety might present with a lot of worry and fear. And usually that fear and worry is in terms of caring for the baby. It's in terms of being able to be there for the baby. We tend in these trainings to not talk about intrusive thoughts or actual obsessions or concerns that somebody might have, for respect. We never know when somebody's in the perinatal period, and intrusive thoughts can be pretty sticky. They're pretty, I don't want to call them contagious, but they can be pretty sticky when we're in a vulnerable state. So we tend not to talk about those specific things. We also see body-based symptoms for individuals with anxiety, where, you know, we're thinking about psychosomatic anxiety, like dizziness, lightheadedness, hot flashes. Sometimes I have people that tell me I just feel, you know, so itchy every so often, like my whole body feels very itchy. There might be some obsessions and compulsions, but not as much as in obsessive compulsive disorder. This is what we call the scary thoughts disorder, because it really comes with a flood of really intense either thoughts or behaviors that are related to something scary happening to the baby. There's a really good book called Dropping the Baby and Other Scary Thoughts by Karen Kleiman. And she talks about, you know, all sorts of obsessions and how to support perinatal individuals during this process. So there's a lot of fear, right, that comes when somebody's having perinatal OCD. Sometimes very scary thoughts that something might happen to themselves, and very scary thoughts that something might happen to the baby. So many times OCD can be easy to confuse with psychosis. I've actually had in my practice a handful of clients that have been what I'm going to call wrongfully hospitalized by, you know, their service provider because they were reporting scary thoughts. The big difference between OCD and psychosis is that with OCD, the person is horrified at having the thoughts. They know that they're wrong. They would never act on them. And they're actually trying to do everything in their power to not make that thought come true, which causes a lot of the you know, distress in functioning. And so, you know, when somebody is hospitalized or something, again, to consider for a BIPOC person, what happens when you go to a provider, you disclose that you're having a scary thought, and next thing you know, the police show up and tell you that they're going to take you to the hospital. And the provider didn't even speak with you about the fact that they, you know, when they went outside, they didn't go to check on something. They went outside to tell, you know, someone to call the police, right? And so what kind of care are we giving when we're so disconnected from, you know, this is a human sitting in front of me? Traumatic birth experiences are also, unfortunately, extremely common. You know, we think about 9% of birthing parents developing PTSD. I actually think that that number is a lot higher because we're not allowed to talk about the fact that we're traumatized at birth when there's a healthy baby, right? Because we quantify a successful birth by a live baby and an alive birthing person without consideration to what the perinatal experience was like, what the birth emotional experience was like. We also have perinatal bipolar disorder. I think that the most important thing that I want you to take away from this is that if you're working with somebody and they're showing up with depression and they're medicated, and maybe a week later they come back and there is a sudden shift in personality, where the person is all of a sudden very energized, very happy, you know, very, you know, glowy, everything's fine, I don't need to sleep, you know, I feel fantastic, that you might be suspecting or keeping in the back of your mind that there might be bipolar disorder. So this is another reminder that as providers, it's very important that we have releases of information so that we're communicating with prescribers, so that we're also protecting families. And then I talked a little bit about postpartum psychosis. We always consider it an emergency requiring immediate help. It is extremely rare and uncommon. Even, you know, when we think about risk of suicidality and risk of infanticide, it is very, very low. So postpartum psychosis happens in 0.1 to 0.2 of all births. And out of that, I want to say it's like 0.3. So from that 0.1 to 0.2 of all births, it's like 0.3 that actually end up in suicidality or infanticide. However, it's still high enough that we need to make sure that we're screening appropriately. And so, you know, going back to this idea that perinatal mental health conditions are complex, they're comorbid, and that it's not only the condition that the individual's facing, but it's the barriers that they're facing to care. And Kima, feel free to take it away.
All right, can you see my screen? I didn't stop sharing.
Yeah.
Do I have to share my screen?
You'll have to share again, yeah.
Oh, okay. I'll do that. All right. Well, as we kind of wind down here, I want to introduce this mnemonic framework for providers to get a better understanding of the core actions in working with BIPOC birthing people. And the easiest way to remember this is CATS. So each letter stands for something different. So I'll go through that. And then after this, we're going to take you into a case study. So the first C is cultural humility. And so what this means is that we are teachable and open to learning from others to become culturally aware. It's a way of being that doesn't really assume that you're the expert or that you're superior to someone else. Even if you have connections in a certain group, you don't assume that you know everything culturally or historically about that group or about that individual. It's also about self-awareness and being honest with yourself about any biases, privileges, or beliefs you have about people who are different from you. And so a really good resource to sort of figure out where you are on that scale of cultural humility or awareness is taking an implicit bias test. The next C is collaborative. So this means partnering with other providers and health professionals to really support that client. So this can be partnering with a doula, OB, alternative medicine providers, a therapist, really beefing up that treatment team, right? Or that treatment support team for that provider, for that client, excuse me. And so having strong professional networks is important. And so that you can better serve your clients and have, a toolbox of resources that you can share. And then A stands for advocate. And so what this means is encourage self. I'm sorry, was there a question? So A means advocacy, and that is not only advocacy for yourself, like advocating for your client, but really encouraging your client to have self-advocacy skills. And so this is a conversation that you as a provider can have with your clients about how do they speak up for themselves when they're in a doctor's office. What's the hierarchy within a hospital setting or with any system that they have to navigate? What is the chain of command that they can access if they have to, seek out higher levels of support because maybe they're not being heard or taken seriously about their concerns? I think also advocacy, I want to point out, as a provider, it's important that you speak up if you witness any poor treatment of clients or people that you're working with by other professionals. That is very important that we do that. Trauma focus is the next meaning here. And so this is where we have a lens that anyone that we're working with potentially can come from an experience of trauma. And so we're not assuming that we know other people's background or what they're coming in with. We are screening and asking important questions. We are making sure that we are creating a safe environment that's built on trust, being transparent in the things that we do and how we are working with that person, and that we are collaborative, we are empowering them, and that we're giving them choice. So this is, we'll talk a lot about that in the next couple of slides here as well. Strengths is the next. Screen is the next one. I mixed it up a little bit. So you want to make sure that you're screening using the 4 R's is what we like to call it. So establishing rapport. And this means that you're not screening just like in a sterile way. You are taking time to really talk to that person and ask those important questions versus just giving someone a handout and really not being engaged. And being responsive is the second R. So being ready to address any concerns that arise as you're screening, as you're finding out that information. The third R is resilience, again, focusing on the strengths of the client. and then what their background is, what they've experienced, what it took for them to actually get there. And then the last R is referral, is pretty much the idea of providing current. So making sure that if you're providing a list, you're providing a comprehensive list that has been checked, that it is still a good resource, and that you're doing it in a timely way, and that it's a warm handoff if at all possible, so that client feels supported in that referral, and there's some follow-up that is done. And going back to strengths, so the last S is strengths. And so we want to be looking at clients, what do they bring to the table? We're not pathological, sorry, I can't say that word today. We're not looking at them from a point of you only have problems and you don't have any strengths. You're not coming with, things that make you resilient. We want to focus on what that client is bringing to the table. How did they get up today? How did they walk in through your door despite all the different things that they had to go through? So this next slide is just a visual representation of the CATS framework. Again, looking at this, it starts with the provider, it starts with you, it starts with your own self-awareness. So starting with, cultural humility, your own self-awareness about that, and trauma-informed care. And then the next section is just, what do you do as a provider for that client? So you're collaborative and you are an advocate. And how do you do that? You screen in a certain way and you focus on strengths. So we're going to take a deeper dive into this CATS framework by looking at each area. And we're going to do this doing a case study example that you should have gotten in your materials.
Yeah.
So we have 53 people.
I think we can do some breakout groups. And so because some of you did not get the documents ahead of time, I'm going to go ahead and share my screen so that we can look at the case study together before doing breakout groups. So I'm just going to go ahead and just read the case study together. So this is adapted from Battling Over Birth, Black Women and the Maternal Health Care Crisis. And I highly encourage you, if this is not a book that you're familiar with, that this is a really good book. So Barbara is a 45-year-old Black woman who was admitted to the hospital for an emergency C-section following concerns with the baby's heart rate. Barbara is diagnosed with HIV and she has been receiving perinatal care at a clinic that provided care to women who have HIV. She shared that she has been in the hospital to complete a stress test, which was mandatory due to her age. Barbara shared that she felt desperate and scared when told that she needed to have an emergency C-section. She expressed having contacted family members who attempted to have her transferred to a different clinic to no avail. Barbara stated that she was treated like another number and that she experienced the medical staff talking about her like she was not in the room. She stated that she had to spend the night at the hospital and had multiple shifts of professional whom she attempted to share that she should not be having a C-section due to her medical condition. She shared traumatic experiences such as the doctor massaging her cervix without using any lubrication, so the glove was actually getting stuck to her cervix, and not having received proper postpartum care, which included over the weekend. There were no doctors that were coming in. Actually, barely any staff had been coming in to check in on her. She delivered her baby at 4 pounds, 13 ounces, was separated from her for a week, and she actually ended up signing her baby out of the hospital against medical advice. So what we're going to do is we're going to break into breakout groups, and your questions for reflection are to think about the barriers that Barbara experienced, to think about what went wrong with her case. How would you use the CATS framework if Barbara was a new mental health client at your practice? Or what could you have done differently in Barbara's care from a cat's perspective in your practice, in whatever role you're serving families from? And so I'm gonna break us into breakout groups. Are there any questions before I do that? Okay, so we're gonna do about 10 minutes in breakout groups. All right, and those of us that are still here, are you having any trouble getting into a breakout room, or maybe you stepped away for a second? All right, feel free to take yourself off mute if you have any questions. Maddie, are you here?
Yes,
Okay.
I am here, and it's looking like there's at least 3 people in each room. So do you want me to move anybody around, or do you think that's all right?
I think that's all right. I'm gonna go ahead and jump into the rooms just to see if anyone has any questions.
Okay, great.
All right. We're just giving it a little bit for the other groups to close and populate. All right, welcome back, y'all.
Welcome back.
How did that go? Any thoughts? Anything you would like to share? Or any questions about what we've shared today?
I have one. Somebody in our group shared, we were keeping in mind the identities when we were discussing the barriers, but he shared outside of identities, it's the way you're dressed when you present at the hospital, the way you talk, the way you present. There are already biases going on that influence the treatment that you get and the care that you get. And I thought that was important because it's like, we don't automatically know what anybody's identity is. We also go by just looks and what we hear, those senses. So I liked that perspective.
Thank you for sharing that. It's very, very insightful and, a reminder, right, of how the system of white supremacy works, right? That we have to look a certain way, and that when we don't fit, the look or whatever the expectation is, that there's going to be, stuff that's going to be thrown onto us that doesn't really belong to us.
Our group, I think group 3, breakout 3, we didn't get a chance to really go through all of it. But I think one of the things that we did talk about towards the end was how helpful it would have been for her to have an advocate there with her, like a doula, a case manager, something like that, because nobody was listening to her, and they weren't listening to her family either when they called to try to get her moved.
A really great point. Yeah, and it definitely speaks to some of the barriers that we have been seeing, right? Is folks not being heard, not being listened to, and even their support system experiencing the same type of biases.
This is a different Sarah. I was just gonna say, thinking along the same lines about this woman's re-entry back into life and medical care, needs. I think having someone to be able to be with her the next time she has to go for a checkup or to the doctor for some reason, I think would be really helpful, because she could feel like immobilized for trauma she experienced before, or just not be able to get her thoughts out in a clear way. I just feel like it helps so much to have someone with you to help either reiterate what you just said, as if you shouldn't need to have someone repeat everything you just said, but the reality is that can be true, or to help you ask questions in a deep way to get your needs and your answers in that moment. I think that could be really helpful as she kind of rebounds from this situation.
Mm-hmm.
Thank you for that.
Yeah,
she shouldn't have, right, to repeat herself or to have somebody there. But the reality is that, we know that, for Black and Indigenous communities, or, for homeless communities, or, for non-binary communities. If you don't have someone there to advocate for you, sometimes it's almost like you're non-existent, like you're not there.
Yeah, and I think it goes back to that idea of teaching advocacy skills, because sometimes folks can't, maybe they don't have a support system or wide enough system that they can have someone with them. So how do you teach them to advocate for themselves and to access systems more effectively, knowing that they may still face bias, they may still have barriers, but at least they have an understanding of how they can speak up for themselves. Maybe one last comment? I know we're down on, I think we have about 5 more minutes. So any questions about the general presentation or anything else with the case study?
It was definitely not person-centered. A lot of violations took place with the healthcare professionals, and which was very alarming. And even in our group, we talked about, with the doctor placing his hands and, not wearing gloves, and the inappropriate touch. Could we have traumatized her if she had ever experienced any sexual violations and things like that to her body? So how traumatizing is that? And the fact that she had a voice, but her voice, it was as if she didn't have one because no one listened.
Right. That's spot on. Yeah. So these are some of the realities of the folks that we work with that we may not ask about or may not know the full picture of how someone presents, and they may have this huge background. And until we really look at a trauma-informed lens, cultural humility, looking at it from those perspectives, we may not really even tap into that if we don't do it appropriately. So we have I'm not sure if you can see let me see if I'm sharing my slides.
Not yet.
Okay, we will go ahead and move on. Okay. Can you see that?
Yes.
Okay. Did you want to share this?
Sure. So this is just kind of like a summary of, what to stay on top of in your practice, right? We know that really establishing a practice of cultural humility, really treating people from an anti-racist and anti-oppressive framework is not something that we do, in one day, in one session. It's really a continuous process of growth and development. So do engage in a process of critical reflection where you are thinking about your biases, your value system, even just like something as simple as like when you think of a parent and you close your eyes, what is the picture that comes to mind? That really gives you a lot of information, right? Really do acknowledge race when you're with your clients, but you can't do that unless you've done your own work, right? But do acknowledge race. If I'm sitting and I'm treating an Indigenous client and I'm not from the community, we have to name what's present. Acknowledge the identities that are present, the ones that the client has shared with you. Talk about the impact of those intersectional identities. And, we think about intersectionality, which was developed by Kimberly Crenshaw. It's really the intersection of race and gender. That's how the theory developed, and it's expanded. And think about, recognize, own the impact of culture. We all have a culture that we come from, right? We all have a value system that was given to us. Some of the things we reject, and some of them we take in. but they're still there, right? They're deep within us. It is impossible for those of us that have closer proximity to whiteness to not have racist thoughts and belief systems and value systems, right? What we need to do is to be aware of that initial thought, right? And then to really work to rewire, right? And to have a different kind of thought, right? And so this work is about leaning into the yuck. And I close today with this beautiful quote that I love, and it's from Maya Angelou: "World of difference between truth and facts. And facts can obscure the truth, right? If we're not careful, if we're not mindful, if we're not asking questions, if we're not looking at systems, it's very easy for us to look at a community and say, oh, Latino families are in mesh and they don't follow up with treatment.
Mm-hmm.
But we have to look at what the truth
Right.
is and how are those systems intersecting.
So here's how you can get in contact with us or follow us. I'm on LinkedIn, so that's the best way to reach me. If you have questions about this presentation, about other things.
Feel free to stay connected, reach out to us. It's been a pleasure to spend this 90 minutes with all of you. Thank you so much for your comments, for your participation, and for the work that you're doing.
Yes, thank you so much.
Come together. Yeah.
Thank you for coming today and learning with us. And I know it was a lot of information all at once and in the case study, but hopefully you have the materials and you can access them later and look at that and just, really use some of these tools that we're giving you. So thank you.
Thanks, everybody. And thank you, Meline and Kima, for sharing with us your knowledge and your experiences. And I know that it'll help us better serve our communities in the work that we're all doing. So we really appreciate you being here. Again, the recording for the session will be on the City Imagineer collaborative website. So you can feel free to keep your eye out in the next week or so. And you should be getting an email from Eventbrite for some feedback. We'd love to hear your thoughts and any suggestions for future ACES quarterly offerings. So keep your eye out in your email for that as well. Otherwise, take care of yourselves and have a good afternoon.
Thank you.